right, I think we're going to get started. Thank you. Sorry for the delay, but we have lots of ground to cover, so we're going to jump right in. I'm Anna Gorman. I'm a reporter at Kaiser Health News, which does not have anything to do with Kaiser Permanente. We're part of the Kaiser Family Foundation, and we write about health for publications across the country. And let me do quick introductions to my panel, and then we will jump right in. Oh, this is kind of loud. I will. I'll talk a little quieter. Sorry about that. Okay, to my right, we've got Kim Yvonne, who's Executive Vice President of SEIU Local 2015, which represents 350,000 home care and nursing home workers throughout the state. Then we've got Hugh Waters, Director from Health Economics Research from the Milken Institute, where he uses quantitative methods to evaluate health policies and programs. And then here to my left, we've got Yuen Lee, Director of Global Strategy and Business Development from Nant Health, a company that focuses a lot on personalized healthcare and improving patient outcomes. And then we've got Josh Offman, who's Senior Vice President of Global Value and Access and Policy at one of the leading biotech companies, Amgen. And finally, last but not least, Claudia Williams, CEO of Manifest MedX, and previously a Senior Advisor for Health Technology and Innovation at the White House under the Obama administration. So if we can start with Hugh, Hugh's going to help set the stage for our conversation by telling us a little bit about how chronic diseases impact California and what those diseases cost the state. So go ahead, Hugh, take it away.
Great, thank you so much. It's really a pleasure to be here. So at the Milken Institute, we do research on various issues that affect our country's economy and our healthcare system. And this is one that is very much pertinent to both of those issues. So just going to briefly talk about the chronic disease epidemic, which it really is, and the economic implications of that, not to mention the human costs as well. So we'll just go to the first slide in our deck, if we could, and we'll present some statistics that will, slide number 3 should be. Yeah, keep going. Okay, and next slide, please. Okay, this is the, okay, next slide, please. All right, cool. This is the slide that summarizes it all. The slide before that, if you're really interested, gives you all of the nitty-gritty on the different diseases that we suffer from here in California. Chronic illnesses. So these are the collection of illnesses that, as you know, they last for some time and they cost lots of money. So most of our healthcare spending in the United States goes toward chronic illnesses. This categorizes them. The slide previous, which we can make available, gives you all the details of all the different diseases in these categories. But if we summarize them, we can see that in California, in 1 year, 2016, direct treatment here means healthcare expenses, doctor's visits, hospitalizations, pharmaceuticals, take drugs, tests, all the things that we think of as spending on healthcare. So in California, 2016, this is data from the epidemiological side, looking at the prevalence of these conditions in California. And from the economic side, looking at how much money we spend on each of those conditions per person, for each person who has those conditions. So if we lump them all together in these categories, you can see that the biggest slices of the pie are cardiovascular conditions. These includes coronary heart disease, congestive heart failure, hypertension. So those are a very big piece of the pie. And then we also can look at cancers, obviously, the blue slice. We can look at diabetes all by itself is a serious cause in the blue in the upper right-hand corner, and Alzheimer's disease. So again, these are just summarizing research we've done. Within each of these broad categories, there's specific conditions where we've tabulated the prevalence and tabulated the cost to come up with these totals. So what does it mean? 2016, the state spent $112 billion on healthcare, okay? Keep that in mind. We'll go to the next slide. If we also look at we call in economics indirect effects, these are in addition to the healthcare costs that I referenced, the paying for drugs, the doctor's visits, the hospital stays. In addition to those costs, the indirect costs include what we call productivity losses. This is people not being able to work at full capacity. It also includes premature mortality caused by these conditions, quantified as only economists can do. You have to get an economist to be able to talk about what premature mortality would cost. But we do, and we quantified it in this way, and boiling it down for the diseases that were in the state, were prevalent in the state in 2016, this is the split. Next slide, please. 378.3. So I mentioned the direct healthcare costs, about $112 billion in California. If we include, in addition to those direct healthcare costs, these productivity losses suffered by individuals, their families, the employers, obviously, this is a major concern for employers, 378.3 billion. Next slide. That is 14.5% of our state's GDP. So when you start to think of it in that way, it becomes, obviously it's a personal issue, each and every one of these people that have these conditions, but it's also very much a social issue, an economic issue. I mean, our economy is being severely damaged by these conditions. So, exporters are concerned about the healthcare bills that they pay in terms of their competitiveness, okay? So those are major issues. Just one more slide, next one, and I promise I'll pass it over. Look at some of the most prevalent risk factors. We'll be talking about this a little bit more later in the day. 61% of adults in California are either overweight or obese. That's probably the single biggest risk factor that we could alter. You can see that that's responsible for a large share of the overall direct healthcare costs. So 36% of the costs for treating chronic diseases are directly attributable to obesity and being overweight. But there's hypertension, lots of other risk factors, alcohol abuse, smoking. Some people call me Dr. Doom or Dr. Gloom. But I promise we're going to turn to the brighter side, which is the solutions. I'm just giving you all the bad news.
All right, thank you so much for that introduction. So as you can see, this is an expensive proposition. So we're going to talk about some of these problems. We'll return to chronic diseases again, but also we're going to talk about some of the solutions. And we've got a really diverse panel up here from different professions. So we're going to kind of keep it at a high level, but I hope you'll follow up offline with some of the panelists. So another big challenge that's facing California is the healthcare workforce. A group of labor and education and medical and healthcare leaders throughout the state recently got together to form a commission to address these needs. And they're starting to look into this and try to come up with some solutions. SEIU is part of that, and they've long represented healthcare workers in California. So Kim, can you tell us a little bit about some of the state staffing issues and what SEIU and labor is trying to do to meet them?
Sure. Good morning, everybody. I want to actually lift up one particular staffing issue that doesn't get talked enough about in terms of the healthcare system and its challenges and solutions, and that's home care. And this was cited in the commission as the need to broaden that workforce outside, the healthcare workforce outside the clinical settings and into home care. And it is the most beautiful option in this state in which people can get cared for with dignity in the comfort of their own home. And it is also something we are not prepared for today or in the next 10 years. The UC Berkeley just issued a study yesterday, and I would invite folks to check it out in detail at cacarecrisis.org, in which they cited, and I just want to lift up a few quotes, that there aren't enough workers to meet the need today or the increased demand tomorrow. The California Employment Development Department projects that the state will need to add 200,000 home care jobs by 2024. That's an increase of 36% of our existing workforce. But if the industry really expanded to fully meet the needs for care, we estimate California would require at least 600,000 and as many as 3.2 million additional workers by 2030. And I want to be clear, currently, the turnover in this workforce is at 33%. So we have a huge, urgent issue that we need to address. And home care, if you talk to hospitals, insurance plans, and medical professionals, they will tell you it is one of the most cost-effective ways to deliver care. And yet we are not lifting it up with any sense of urgency to have that as an option and to really think about its vital import in the healthcare system. And also, if we can't attract enough workers, the choice will be for people to go into institutional care, which is, 30% to 40% more expensive, and not an option most people want. And so we really have to address it. And I think some of the things we're doing right now, and not just us, but our members in SEIU who do this work, since the 45th occupants of the presidency was seated, we have been really defending and protecting the existing Affordable Care Act, because unless we have a better solution, we are going to make sure everyone still has access to health care. Defending and protecting Medicaid, which is now being looked at, attacked through their tax proposal and their budget. And so those are the ways that federally we're doing that. Locally, at the state level, we've been incredible proponents and advocates of expanding Medi-Cal. You name it, we're on the front lines, but we do that, we know, in partnership with many people who care about this issue. So that's what we need to continue to do.
Thank you. I mean, and these are our parents, these are our grandparents that need to be taken care of, and there are tremendous workforce needs in that, just as there are in primary care and in mental health care across the state. So one of the things that you all have done is helped fight for minimum wage.
Yeah.
I mean, or $15 minimum wage. Is there enough investment in healthcare workforce here in California?
No. I'm just like,
that's easy.
There's no technical explanation, no. Look, raising the minimum wage is a start for both caregivers and 6 million other Californians, but the reality is that this workforce has been undervalued historically. They're mostly women of color, and immigrant women. And part of the UC Berkeley report, some things that really need to be lifted up. In 2015, the median hourly wage was $10.05. The annual median salary was $14,000. These are people who take care of other people. 3/4 of home care workers are classified as low wage. 40.7% themselves get health care through publicly funded programs. It just is insane. So we need to make a huge investment in this workforce, that these jobs are jobs with dignity. And most of these workers do not have access to an employer-paid retirement nor Social Security. And so that's one thing. The other thing we need to do is really invest in training and development and partnership, because although they are an integral part of a care team, they are with the care recipient more than any doctor, social worker, or nurse. They are rarely invited into the discussion about their recipient's care, and there is proof. In fact, the California Long-Term Care Education Center got a grant from CMMI, in which they trained 6,000 providers with their consumers. And at the end of that training, they saw reduced hospital stays, reduced ER visits, and reduced costs, because they were invited to be part of that care team and really inform and observe and be taken seriously. So we have a lot of investment to do, and we need to do it now.
Excellent, thank you. So let's switch gears here to prescription drugs, another big problem and solution at the same time. So as you all know, there have been incredible developments in prescription drugs recently with hepatitis C cure, essentially, but they've also come with a very high cost. It's obviously been in the news. Josh, let's turn to you. So what are some of the reasons for the rising cost of specialized prescription drugs?
So, first of all, as the leading biotech company at Amgen, all of us in the industry take very seriously and are concerned about rising healthcare spending. And obviously, there's been a large focus on how much we're spending on prescription medicines as part of that overall spending. And we need to put that in a little bit of perspective. So let me take a moment to do that, and also talk about the reasons for this. So the first reason for this is that we are literally on the breakthrough in science right now, and having a complete revolution in biomedical sciences and human genomics. And so the discoveries that we are developing right now, novel targets, the use of human genetic information, molecular biologic techniques, are availing us of unbelievable new technology. So the medicines that we're developing, like biologic medicines, you have to keep in mind are very different than pills that are made in laboratories, small molecule pills, generic tablets. These are biologic medicines that are produced in living cellular systems, highly complex to develop, to manufacture, to distribute, et cetera. So these are the medicines that are associated with high costs and are often the ones that are focused on as the most rapidly growing part of the prescription drug spending. So there's a big focus on that. But let's take a big step back now for a minute and recognize what those medicines are intended to do. What's going to make healthcare unsustainable in this country are the data that were just discussed earlier, which is the rising cost of disease. Okay, so let me just focus on cardiovascular disease for a moment. In this country right now, we spend about $600 billion a year on the direct and indirect consequences of cardiovascular disease. That's expected to rise to $900 billion by 2030. It's the #1 killer, and while I've been talking, we've lost several people to cardiovascular disease already because one person dies every 40 seconds. Cancer is the #2 cause. We're losing about 2,000 of our loved ones a day, and these biologic medicines are focused on figuring out how to address the most grievous cancers that we have. And finally, the thing that's going to really make healthcare unsustainable is the cost of Alzheimer's disease. So Alzheimer's disease is afflicting over 5 million people now, and it's expected to cost society in this country well over $1 trillion by 2050. So as a physician, those numbers are completely unacceptable. And the best hope that we have of changing the cost trajectory of those diseases are novel, innovative biopharmaceuticals like biologic medicines. So very often those medicines are being viewed as the problem, the cost that's rising, but in fact, we very much view them as the potential solution to the problem of the rising burden of disease. And in perspective, again, of overall healthcare spending of the $3 trillion, all medicines account for somewhere between 14 and 17%, depending on how you count it, of all medical spending, and that's been consistent for decades now. So we have to keep the cost of prescription drugs in perspective, recognize that while specialty drugs, biologic drugs are increasing in their spending, overall drug spending has been very moderate and for decades now, and are the potential solution to the real problem, which is the rising cost of disease.
So these specialized drugs, of course, it's very difficult for counties and states to kind of cope with these rising costs, and insurers as well, right? And so one of the possible solutions that I actually don't know much about, so I'm hoping you can talk a little bit about it for the audience, is to allow insurers to pay less for medicines that don't meet certain outcomes or certain benchmarks. So how does this work, and can it help bring down these rising costs?
It can. It's a great question. So what we're talking about here is how do we bring more value into the healthcare system? So these medicines have high price tags. And what we try to do is price these medicines commensurate with the value that they deliver to society, to individual patients, to the physicians, and to the healthcare system. But value holistically. How much are they improving quality of life, human productivity, how patients feel, how long they live? All those parts are value. Now, many of those are difficult to quantify. Sometimes we do it better than others. So what we try to do is partner with the payers. So payers are focused on their short-term budgets, insurers, PBMs, and that's understandable because healthcare costs are rising. So are employers. They're focused on their annual spending on insurance. So how can we work together in partnership to bring more value into the system? So what Amgen has done is taking a leading role in partnering with these healthcare systems, insurers, PBMs, and employers to try to share risk. And so when we bring a medicine to the market, we just brought a new cardiovascular drug to the market, a biologic medicine for patients who don't respond to usual therapies, who have high cholesterol. These drugs can dramatically reduce cholesterol, but they have a high price tag. So we partner with these organizations and stand behind the value of our product, and we say, listen, if patients have heart attacks and strokes while they're taking our medicine, we're going to pay you back for the medicines that you've paid for. If their LDL cholesterol, their bad cholesterol doesn't fall by a certain amount and our product doesn't perform the way we expect it to, we're going to give you a much bigger discount and rebate. So these are ways that we can partner to bring more value into the healthcare system and to share in some of the risk, because all of this is uncertain.
So let me ask one last follow-up question on drug pricing here, and that's California passed a drug transparency bill recently that requires certain companies to report certain price hikes for prescription medicine, but other drug price measures have failed across the country. Is legislation an answer?
No, we actually believe that market-based solutions here are the best way to drive more value into the system. We know from around the world that direct price controls are largely ineffective and really stifle innovative companies from doing R&D. If you think about just Amgen for a minute, when we price a medicine and bring it to the market, we're asking several questions. First of which is, can we generate a return on this medicine that is sufficient to support what's a $3.5 to $4 billion a year R&D engine? That is an engine of investment that has very high risk. About 95% of all of our human clinical trials fail. So those are the types of questions. So in price-controlled markets, you see very quickly that there's no innovation happening. Those companies are not innovating in those markets because the risk-reward is not there. So it's a really important, transparency is a good thing. We want transparency throughout the whole chain of healthcare, from the biopharmaceutical manufacturer to the intermediaries and the PBMs and the insurers, all the way to healthcare systems and institutions. So that's good, but we need market-based solutions, and there's some regulation that can help develop better market-based solutions. So there's things like Medicaid best price legislation, anti-kickback statutes, and regulatory from the FDA restrictions on the ability that biopharmaceutical companies have to talk to the payers. Okay. And so if those are addressed, we think it will stimulate more of these value-based types of arrangements, which are market-based solutions to the challenges around value.
Thank you. So let's turn to UN. One of the most exciting developments in medical treatment today is precision medicine. So I'm hoping, UN, that you can give us a quick primer on how government and companies are working to use data and technology to tailor treatment to the individual. And then we'll turn to Claudia to talk about how this worked in President Obama's administration. So UN, why don't you just give us a little bit of background on this and how it can be used to cut costs and improve quality?
Sure, thank you, Anna. Let me do a survey first. How many of you, raise your hand, heard of precision medicine? Great. How many of you think you know what precision medicine is? Don't be too shy. It's already a room that has a higher knowledge than precision medicine than the average American. Based on a recent survey conducted by Precision Medicine Coalition, 62% of Americans never heard of this term. So what precision medicine is, broadly speaking, it is a new way of treatment and prevention take into consideration of individual variety in genomics, genetics, lifestyle, and environment. And more narrow and more technical definition of precision medicine is an emerging field of using diagnostic tools, mostly genetics, to identify biomarkers that can help determine the best treatment solution for individual patient, as opposed to look at patient as a cohort, as an average person, because everyone is different. So I know Claudia is going to talk about the precision medicine initiative that under Obama administration, so I will skip that part. In terms of how companies is using these technologies and science to innovate, I would give you some examples. So I would say there are two cohorts of companies in precision medicine. One is related to cancer research and cancer treatment, and the other one is more not cancer, lifestyle prevention. So in the cancer cohort, there's a company based in San Diego called Grill that is trying to use liquid biopsy, i.e. blood, to do early stage cancer detection. There's another company called Myriad Genomics that use cancer genomics to assess your risk of getting cancer, especially if you have certain family history. And then also within this cancer cohort, there are other companies in the cancer treatment decision support group, which including NantHealth, the company that I work for. So just give you an example of what we're doing at NantHealth. We developed a late-stage cancer diagnostic tool called GPS. It's not the GPS that you drive your car with. It actually stands for genomic proteomic spectrometry. So we use that very comprehensive genomic testing to testing the entire genome, transcriptome, and quantitative protein of a cancer patient. So with that information, we give physician the comprehensive molecular profile and signature of a cancer patient. So we know exactly what's the driving mutation that caused cancer and what the targeted therapy, what clinical trials that we can match this particular cancer patient with. So those are the cancer group of companies. And then there are other companies that doing less, not cancer, but more lifestyle related field. And I call them precision wellness. There are companies called Pathway Genomics, Helix. They're both based in San Diego, or in California. What they do is they do a genetic testing, and based on the result, they tell you what type of food that you need, what's the best exercise to lose weight, what's your metabolism, what drugs work or not working. So those are the things that companies in this space are trying to do. And Anna, to your question, how does precision medicine improve outcome and decrease cost? So Josh, you mentioned a lot of money is spent on cancer care. So correct me if I'm wrong, I think over 40 billion per year is spent on cancer drugs. But 25% of the patient on average benefits from the given drug, which means 75% of the drugs are wasted. So there are a large waste in the cost system. So using precision medicine, if you can already identify the right treatment on a personal level, we could actually save cost and reduce the waste. Give you an example, for a breast cancer patient, if they receive a BRCA test before treatment began, more than 30% of chemotherapy, unnecessary chemotherapy would be reduced. And if a colorectal cancer patient received a KRAS gene test before the treatment began, over 600 million cost will be saved in the system. So we do at Manhouse, we believe precision medicine is a paradigm shift in healthcare.
It sure seems like it from the business side. Let me turn to Claudia.
Could I just amplify something you said
Please.
real quick? Because I think it'll tie it together, what we're talking about.
Absolutely.
So to just amplify what she just said is critically important, because from a payment policy perspective, everything is dealt with what I'll call epidemiologically, or on the average patient. And so this movement that she's referring to is a movement to what we call radical personalized medicine. And the challenge with that right now is that it's going to lead to unbelievable benefits for patients, but we live in a very antiquated system of payment policy and coverage. So from Medicare to Medicaid to the private insurers, they're still basing their payment and reimbursement on a very antiquated system around average populations, not individual patients who have very specific individual needs. So the science and the medicine is going in exactly the direction of which she speaks, which is critically important for outcomes. But the payment system needs to catch up. A colleague of mine, Mark Fendrick, likes to talk about how we're practicing Star Wars medicine in Flintstones healthcare. And he's absolutely right. And if we don't align those two things, the benefits and the power of everything you're talking about will not be realized. So that's why from a policy perspective, we've got to jump on this problem. And I think the government's initiative was part of stimulating that, as is the 21st Century Cures Act and others. So just wanted to highlight that.
That was a perfect segue. So Claudia helped found the Precision Medicine Initiative under the Obama White House. So what was the goal of that, and how can it, or could it, bring together the business side and all this innovation with real patients in real scenarios?
Sure. I think you'll hear in both my remarks about that, but also talking about the new organization I run, sort of three themes: bringing data out of its silos, making it available on an open platform, and liberating it for discovery. So let me talk a little bit about how those three themes were really tapped in the Precision Medicine Initiative. So two of my favorite thinkers in this space, one, my old boss, David Blumenthal, the head of the ONC, used to say that information is the lifeblood of health improvement. And Tim O'Reilly coined the term government as platform. So the idea of the Precision Medicine Initiative was audacious and simple. If we could bring together data from 1 million Americans, whether that's genomics data, wearables data, data from your health records that are locked in your provider's system, and make those available on an open platform for the discovery by any number of different folks who might have innovations or might have breakthrough ideas. And importantly, that set of innovations could include patients, it could include biohackers, it could include folks that are entrepreneurs in Silicon Valley. And the premise is if we can do that at scale, and that is what has been launched now as the All of Us cohort that NIH is running under Francis Collins and Eric Dishman from Intel. If we can do that at scale, then we'll be able to accelerate the kinds of discoveries that you've heard about here. But it's important to remember it's not enough to collect the data. The data are collected every day across the healthcare system. It's important that we do that in an open way that actually makes the results of that labor broadly available, and not just to a particular segment of industry or a particular segment of people who might have access to innovation. President Obama also did this in a way, it was very interesting being part of these discussions. For him, it wasn't about starting a new research study, which is sort of Framingham on steroids. It was also about asking all of the partners across industry to reflect the same principles that would allow us to have a platform. Opening data to patients and enrollees themselves, making data available from industry to other innovators who aren't at the table, not leaving anyone behind, not leaving behind folks who might be on Medicaid or might have disabilities. So we did a lot of work not just to create this new thing, but also to engage a whole lot of partners across the healthcare industry who had a lot to learn and a lot to contribute to this mission.
So staying on that theme of data, when I'm on the ground talking to patients, I meet patients all the time who've gone to one hospital to the next, and sometimes the hospital then has to start from scratch, and it leads to a lot of duplication and testing and a lot of unnecessary costs because hospital systems aren't sharing information. So how is your company, Manifest MedX, addressing this? And I know it's involving a lot of hospitals and payers and insurers. And so why are these organizations who normally would compete with one another, why are they starting to work together?
Great. Well, remember these three themes of bringing data from its silos, making it available on an open platform, and liberating it for discovery. That's what we're doing in California. So we are a health information exchange to create, and there used to be exchanges, these infrastructures created by government or created by cities, were created by those same partners that are trying to share health information to improve care. Health plans. Blue Shield, Paul Markovich spoke this morning, is one of the founders of our efforts. So we bring together claims data, clinical data, data from labs, and make it available to a broad range of participants, more than 60 hospitals, 4 health plans, and growing every day across the state. Now, why would you have this kind of collaboration from organizations that otherwise are competing for the same business? I think it's the recognition, if we go back to this idea of platform and information as lifeblood of improvement, this is an area that these folks recognized they could not do on their own, and we needed to create pre-competitive space. We need to create shared resources so we can all build value based on the information and not have a million HL7 interfaces all going to the exact same EHR system. So the premise is that pre-competitive space and bringing together the data, protecting it, and making it available in easy-to-use ways is a great accelerator to the kinds of innovations, not just in drug discovery, not just in precision medicine, but frankly, in the nuts and bolts of providing care in the home, across the healthcare system, chronic care, everything that we've been hearing about.
So data obviously plays a big role in some of these solutions to the biggest problems in healthcare, but so do real people, right? So to help keep people out of the hospital from the start or help them from getting their chronic diseases out of control, LA County and other places are pairing chronically ill people with what are called community health workers. And this addresses these issues that really impact people's health, where they live, what food they're eating, their transportation. But there's often not a way to reimburse for that care. So Hugh, can you tell us a little bit about this community health worker model?
With pleasure. Thank you. We at the Milken Institute, in our health economics group, we've actually done a fair amount of research on community health workers and how they complement the formal healthcare system and offer a bridge in many cases between populations that might otherwise have difficulty accessing healthcare and the actual formal healthcare system. So our work, and I would actually point out Ken Sajinbekov and Marlon Graff, who are both in the audience, that are the authors of this work, but showing that if you look in 2015 across the United States, every additional community health worker adds added value and saves lives in the U.S. And the community health worker force in the U.S. in 2015, the most recent year that we have data, is associated with 165,000 lives saved across the U.S. So, doing our statistical modeling, holding everything else constant, the community health worker force in the U.S. is associated with 165,000 lives saved. And the value of that is astronomical in economic terms, potentially as much as $500 billion if you look at the value of those lives. So we have very strong evidence that community health workers are playing a pivotal role in getting people access to care for these chronic conditions so that they get treatment earlier before the conditions worsen, and playing a role in terms of translation, sometimes literally and sometimes figuratively, between healthcare professionals and the population. It's very promising work.
And I was sharing a story with you earlier that it's not just the money, right? It's the people. That I met a woman who had been paired with a community health worker. She kept going back to the hospital for high blood pressure, and it turns out she couldn't read her label because she was almost blind, and she hadn't told her doctor that, but she told her community health worker. A barrier to some of these healthcare solutions that we're talking about is scaling them up. One hospital, one company, one county might have some success, but then it doesn't really take hold across the nation or California. So I don't know who wants to take that, but why is that? Why is that? And what can be done to scale up some of these solutions?
Can I
Please.
So a big part of the push to transform healthcare in the Obama administration that continues today is really paying for the outcomes we want. And we heard an example on the drug front, but obviously alternative payment models, whether those are accountable care organizations or medical homes, are a way to say, let's stop paying for the widgets and let's start paying for the outcomes we want. Incidentally, when you start doing that, that's when the demand for data and technology skyrockets, because people start to recognize that they're not in the business of producing that thing. If they have to actually care for somebody in their home with a home care worker and that person doesn't have an air conditioner, that becomes the smart investment to make in their future. So we are at a really critical juncture of time when we need to pair the coverage expansions we've had, smart looks at policy, with a steady drumbeat from both the commercial sector and the government to say, we are on the path to transforming how we pay for care. We're going to support you in getting there. We'll make sure you have the data you need, the technology that you need, because we need to recreate the basic ways the pieces of payment, the providers and patients come together. And that trajectory is the one we need to be on. The faster we can help physicians and other people in the system not have a foot on the dock and a foot in the boat, but actually be sailing with good winds into the ocean, the better we're going to be. So I just want to say, I know this is an area of bipartisan support. If you look at the macro legislation, huge bipartisan support. And we as an industry and we as a community need to continue to support those efforts and frankly accelerate them as we go
Macro
forward.
legislation, can you?
Okay.
We
How
may
far
not
back
all
do
have
we
all
go?
healthcare people in
macro,
here.
It essentially pretty fundamentally changed the way physicians who get paid by Medicare get paid. Now remember, that's a huge bolus of the funding that goes into our healthcare system. So now they're being asked to invest in improvement, invest in data, invest in quality measurement, or jump into one of these alternative models as a way to actually move the ball forward. So physicians across the country now are getting prepared for this new payment model, and I think many other payers are looking to that as a template for things that they can also do in the payment that they also offer to physicians. We could go into SGR and everything
But
else,
maybe I
but
can
it's not.
just-
But we're not going
Not
to.
going
Go
there.
ahead.
No.
Comment on that. I think what you're asking is, why do we still have a cottage industry of local health care? And I think the answer is because of the way we've always paid for health care. So paying for volume as opposed to paying for value, this is, I think, what you're saying, is this transition from paying for volume to paying for value is a transition that has to happen. It requires a very robust data infrastructure so that we can actually pay for performance and pay for value. But right now in the current system, there are so many perverse incentives to maintain this cottage industry of very local healthcare that it's preventing the ability to consolidate at the right levels in healthcare to get the right kind of competition, the right kind of outcomes, and to eliminate the $700 billion of waste that we have in this country every year, and the $300 to $400 billion of inappropriate services that we deliver to patients every year. So I think this movement is mission critical, but it's the way that we're paying for healthcare that is creating and maintaining this kind of very local cottage industry that is introducing all kinds of perverse incentives into the system.
Yeah, and I also want to chime in here on the barrier of precision medicine and how we can increase adoption. Exactly as you said, Josh, payment is a huge problem in this industry. Not only insurance company, very few insurance company cover precision diagnostic testing. FDA also shied away from regulating next-gen sequencing. The genomic diagnostic testing, very few of them are FDA approved. And another really big problem is a lot of the physicians, they don't understand genomics. So physician education, a quarter of physicians, they're not confident of making treatment decisions based on genomic data, or they're not confident on their own genomic knowledge. And 1 out of 10 patients said there's only doctors. Patient says 1 out of 10 doctors give them recommendations based on genomic testing. So I think empower patients, educate patients, educate physicians would also drive adoptions, because more physicians order that will incentivize or enable the payers to cover more testing, and that in turn will enable FDA and agency to develop a clear pathway of regulate this market.
I think what you're saying is that if we make this transition from paying for volume to paying for value, we have to change the whole way we think about our healthcare system, which right now is a break it, fix it type of model. So if somebody has a horrible fall and breaks bones, they get shipped off in the top flight ambulance to the top flight hospital and get the most amazing care in the world and pay very little out of pocket to get that done. But if then you say, let's take the right medicines or do some genetic testing to see who's at risk, give you the right medicines to prevent that fracture, nobody's willing to pay for that, right? Preventive medicine isn't even paid for really in many aspects of Medicare and other private health plans. And medicines, there's a huge out-of-pocket burden, much more than for hospitals and other care. So we've got to move to a prevent, predict, and protect model of healthcare. And I think that movement from volume to value can facilitate. I think they're synergistic, but if we don't do that all, I think health outcomes are going to continue to suffer and costs are going to continue to rise.
So let me ask one final question, and then I want to open it up to a few questions from the audience before we have to end. And that is that being here in California, we can't have a panel about healthcare solutions without recognizing the diversity of the state, right? We have 1/3 of the state on Medicaid or Medi-Cal here in California, very poor. We've got tremendous linguistic diversity, cultural diversity, racial, ethnic diversity. So how does that, let me turn to this side of the panel, how does that make things harder to bring these solutions to bear? And are people being left behind?
Yeah, so I would say, this is also an issue and a goal of the Commission on the Healthcare Workforce, which is to address the underserved, disadvantaged populations in our state, and we have to close the gap. If we're going to do anything around healthcare or innovation, it has to also be in service to closing the existing gaps that are already present. I would say, I was listening to Josh when he talked about radicalized personalized medicine. It would be radicalized medicine for people in rural counties in the state to actually have access to a doctor.
At all.
That's radical. And they, the stories I can share with you is caregivers and consumers who I talk to all the time who have to travel 3 to 4 hours, 3 counties away to get healthcare services. Never mind just simple infrastructure, clinics there and a hospital or, access to more advanced medicine and services that they need. I think we have to place a value on staffing. I think it was mentioned earlier about healthcare workers who, from physicians to frontline staff, value on linguistical skills, cultural competencies. There are many folks who literally wait 6 months for a doctor's appointment because they don't have someone who can talk to them in their language. We have folks who go home and come back in the hospital because the medical directives they got were misunderstood because of cultural nuances, even in interpretation. And I would say the other thing is technology has to speak to connecting consumers of care who are just not bilingual. There's a lot of incredible technology out there online. I think we have to look at how are we looking at this population and making sure we're not leaving anybody who's not a monolingual English speaker out, as well as infrastructure for tapping into technology. There's lots of rural areas in this state that don't even have good access to internet. So I think these are some of the things we really need to pay attention to as ways to close the gap.
That's a great answer.
Excellent. Let me open it up to the audience.
Can I just,
oh, yes, please.
Let's not forget that the closer of the gap has been expanded health insurance. And that is such a huge, that what has closed a big part of this gap is that people actually have health insurance coverage who didn't have it before. And so as something that we need to maintain that keeps people from falling behind in this state, Medi-Cal coverage, Cover California have been substantial investments in trying to make sure that everyone has access to care. So I think sometimes we forget that we take that for granted, but we know from the debates going on we can't.
If I could just add to that, again, the importance of community health workers and kind of bridging that gap, particularly for populations that have, they don't speak the right language that providers speak, or the community health workers play a really important role, not just in connecting physical access, but connecting cultural and linguistic access, and that's what we found with our research. I wanted to point out really quickly one other thing, just coming back to my Dr. Doom profile here. The state's demographic projections they suggest that our population in this state is getting dramatically older, right? So despite the fact that we have a healthy dose of immigration, which tends to be a younger population, in 2016, last year, 14% of our state's population was age 65 or older, 14%. In 20 years from now, it's going to be 23%. So it will have almost doubled in that time span as a ratio of our overall population. If we go back to the diseases that we've been talking about, the chronic illnesses, they're highly concentrated in the elderly. And so these problems that we're talking about are not going to get better from a population perspective. And the solutions that we're talking about are going to become that much more important for our population, whether they're community-based or whether they're technology-based. We need to deal with the crisis of chronic diseases.
That's a great point to end on. Let me ask the audience if anybody wants to ask a question of any of our panelists.
Oh, do I get a microphone or anything?
Yes, you do. Here we go. Coming to you.
Thank you for educating us today on healthcare. I'm not a student of healthcare, so I'm glad to learn more. And what I understand is that the system has some problems. There's a lot of costs. So where do you see the system in 5 years? And what's one action item that each of you would like to see that's really crucial to make it to be where you want it in 5 years? And even if it's impossible, what's one thing?
I love that question. I usually end panels with that question.
That's a great
If
question.
you could run the world, what would you do?
Where would you
So
start?
why don't we just go through it real quick? What would you do that would make things better, that would address some of these problems?
You said could I have a dream moment? Yeah. So let's just say the federal government isn't in the situation it's in right now. That we would have a really robust budget that Medicaid and Medicare that not only advances the quality of life for everyone, and that to me moves us closer to this notion of universal health care, that it's a right, not a privilege.
And that would be a subject for a whole nother conversation, the single payer. Go ahead, Hugh.
Sure. Thanks for the question. My sense is that we need to really address the prevention factors for the chronic diseases, and so I think that's where I think the things like telemedicine and precision medicine are incredibly important, right? So that's for making our healthcare system itself more efficient. But we have to give equal attention to the other end of the system, which is preventing people from getting sick and having to go into the healthcare system in the first place. And I think that the evidence is pretty clear that a lot of the chronic disease burden is preventable if we could find ways in our society to promote better behaviors around healthcare and health behaviors.
Ewan?
I'm a huge believer of precision medicine, so I'll have a very practical dream. I hope that the payers covers the genomic testing. FDA actually do not shy away from approve and regulate the space, so everyone have the right to understand their genome, because that's yours. It's the blueprint of all of us.
Josh?
Mine is to move away from this antiquated payment system that focuses on break it and fix it and paying for volume, and reinvents itself to one that focuses on predicting, preventing, and protecting patients at a very individual patient level instead of population averages. And that will facilitate the type of innovation that will bring down the burden of illness.
And Claudia?
So I think the federal government's done a lot to do just that. I think California can step forward and be a leader for the nation. What would that look like? It would look like a common information backbone that's not locked behind the paywalls of any vendor or any provider, that is then paired with creative and ambitious payment strategies that support health in your home, health in your community, and meaningful relationships supported by technology with your providers. So we have an opportunity to really be leaders in the nation. This is exactly the right group of people to figure out how to make it happen.
Excellent. Any other questions? Oh, we have a quiet group here. Is there one in the back? There we go.
So it seems to me that one of the things that holds us back from this transition, as you've been talking about, from volume-based care to value-based care and preventive care, is that the system, as we currently have it, serves a lot of the participants in it quite well. And that one person's cost is another person's revenue. And so there's a reason why we have the system that we have today, and this transition that you're talking about is going to create winners and losers. And that's the part of it that's not talked about that much. When we have this debate, the docs blame the hospitals, and the hospitals blame the drug companies, and everybody blames the health insurers or the government, depending on their political philosophy. And so my question for you is, how do we get past that? How do we start having a conversation that says we're all a part of this, we all have to take responsibility, both for dealing with the social determinants of health that are causing the illness, and we have to deal with the fact that we are spending more money on healthcare and getting poorer outcomes than every single other industrialized country in the world. We are last. So how do we begin to have that conversation? Because we're not having it. We're having a conversation about how to finance it and what's the role of government and should we have single payer and should we not, and how we're going to pay for it. But we're not having a conversation about how to at the political level of how to really transform the way we think about healthcare, as you're all talking about.
And is that possible in a capitalist society where you've got different business interests and different competitive interests? That's a tough question. Anybody want to jump in?
Well, go, please.
No, I've done a lot of work around patients as innovators, and one of the awesome things about talking with patients is it's all bullshit to them. Like, they're like, I don't really care about that thing you just said unless it's gonna help me. So I think finding those voices that rise above the sort of discrete interests, employers, it could be politicians if we could have such a thing, and patients and patient groups themselves. It's not a solution, but I think it helps articulate the possibility that we're not getting to. But I think there will be winners and losers. So I don't discreetly know how you manage that, but I do think that if we can empower the voices that where the buck stops with them, because they're not going to be healthy and they're going to be sick and their communities will be sick. And things like the opioid crisis, I think, really can be used as a magnifier lens for the kinds of problems that happen when we don't actually think about the health of that person. So I don't know if what's going on in California right now around that, and the opening up of the cures data, and the recognition that there's a community piece. Maybe some of those kinds of crises can help us see, like, this is what we get when we haven't thought in this holistic way. And we need to think, those are,
I would
don't
just
And
think-
maybe
add,
patients can help drive that solution.
I think they can.
I think keeping patients at the center is critical, but I will tell you that at the national level, those conversations are happening. The issue is nobody's really willing to get into the perverse incentives in the system. And everybody has developed a business model around that set of incentives. So the solution to this problem is aligning those incentives, which is a very difficult task. And currently our political system isn't really up to that task. And so I think that's the challenge. But there are groups that are bringing multi-stakeholder together to dive into this and to discuss it. So I'm optimistic, actually, that some substantive change is going to happen with market-based solutions, but we have to address the perversities in the system and the waste in the system, because there is plenty of money in the US healthcare system to achieve the outcomes we all know are possible. That's not the problem. It's how that money is allocated and how wisely it is spent.
And we've seen some of that here in California too, around maternity care, when payers and businesses started to see their costs going up because too many women were having C-sections. They worked together with hospitals, with payers, with businesses, with patients, with nurses on the ground, and they opened up the data to show which hospitals were doing better and which ones were doing worse, and that helps drive some of this cost reduction and cooperation. I think this will be our last question because we need to close up. Oh. Okay, here we go. Please, go ahead.
Well, I just want to endorse, I don't know you, but I want to endorse everything you said. I'm on the board of the largest healthcare system in San Diego, and you have no doctors up there, you have no healthcare systems up there, and those are the people who are confronted with making huge decisions about where to invest, about, as we did, participating in the accountable care organization systems and other things. The system won the Malcolm Baldrige Award. I mean, it's a great run institution, but the financial uncertainty that is caused by the political uncertainty, the fundamental unfairness to doctors of having government health care not even cover costs, and then the intrusion of all these other people, including insurance companies and others, in the healthcare decisions, and then finally, I guess, the legal system, which makes every doctor and every healthcare system on the defensive to try and just protect its interests from frivolous lawsuits while being fair to people who are injured. All of these systems, and so I think it's been an excellent panel, but it would benefit by having physicians and healthcare systems involved as well, because we're right at the nexus.
I am a doctor, but I play one on
good,
TV.
okay.
You're absolutely right.
Thank you.
You're absolutely right. That would have helped to broaden it out. There's a lot of solutions, and the healthcare systems are the ones who see the problems firsthand, and there's a lot of solutions going on there. Well, thank you so much for attending the panel. Thank you so much to our panelists and for covering so much ground in such a short period of time. I hope you will follow up with us afterwards, and thanks again.
Thank you, Anna.